Hi. So we're down to our last our last hormone lecture, our last of the endocrine system. Let's look at what we've done so far. We started off with the hypothalamus, which receives the signals from all over the body and decides what needs to be done. It sends out its releasing hormones. These are trophic hormones that will turn things on. It sends out its releasing hormones down the pituitary stalk, that hypophyseal portal system, into the anterior pituitary and causes it to release its set of trophic hormones, which are things like thyroid stimulating hormone and ACTH, adrenal cortex stimulating hormone, growth hormone, which stimulates all the body. It's certainly trophic. The gonadotropins to stimulate the gonads to make sperm and eggs, and also hormones. Prolactin, which stimulates the breast to develop and start making milk. And then it sends out its two neurohormones out of the back. And then those target glands, the thyroid and the adrenal glands, send out hormones that go directly to the cells and have their effects. All the hormones coming from the hypothalamus to the pituitary are water-based. All the ones leaving from the pituitary are water-based. They're all water-based until they reach glands like the thyroid gland or the adrenal glands or the gonads, and then they produce those steroid-type hormones, which will tend to go into the nucleus and have effects on the nucleus. We know what the main effects are of those hormones, and so we know what's going to happen if you have too much or too little. And we know what the negative feedback is. It's that last hormone. When it gets high, there are receptors on the hypothalamus and pituitary, and it slows them back down. So it says you have enough. So we've done a pretty good job with those guys. Those are the main hormones. You got tons of little teeny ones that work very locally. Maybe you've got some in the brain. You've got dopamine and serotonin, and that some of those also show up in the GI tract. But the main ones that we normally see that are going to cause physiological problems are the ones that we've gone over. Now we're going to go take a little bit different track, because there are a couple of hormones here that don't respond to other hormones. They respond to the stuff they're trying to control in your body. So we're going to control blood sugar, and we're going to control blood calcium. So the stimulation for these is more or less blood sugar and more or less blood calcium. They have receptors that will tell what the concentrations are in the blood right on these glands, and they will either give you more sugar or less, or more calcium or less. The pancreas controls your sugar, your glucose, plasma glucose, and your parathyroid and surrounding cells control calcium in the blood. Let's start off with the parathyroid and calcium ones first. First of all, you have calcitonin. Calcitonin is a not very powerful hormone. It helps you put excess calcium into your bones. It's easy to remember, to calcify your bones, you need calcitonin. Calcitonin puts calcium into the bones, so it lowers your plasma calcium levels. Calcium is critical. It runs a lot of processes. It causes heart contraction. Comes in during the plateau phase of the cardiac action potential, and it has to be pretty well controlled. So if you have a little bit too much plasma calcium, you put it into the bones for storage using calcitonin. It makes your osteoblasts work more, and inhibits your osteoclasts so that you don't take the calcium out of the bones, instead you put it in. The parathyroid glands themselves, and those calcitonin cells are right around the parathyroid glands. The parathyroid glands are 4 little dots that are on the back side of your thyroid gland. So on the lab practical, which the next lab practical is going to be all the blood vessels and the endocrine glands. The endocrine glands are easy. It's easy to pick out the thyroid, the parathyroid, the pituitary, the adrenal glands. They're right on top of the kidneys. So those are going to be some really easy questions for you. But for the parathyroid gland, I'm going to have to use a picture because it has to show the back of the parathyroid. I mean the thyroid gland. The parathyroid hormones come from the parathyroid glands that are stuck onto it. Don't mess up and on the test and say, well, which of the following hormones come from the pituitary? Don't say thyroid hormone. That comes from the thyroid gland. Don't say parathyroid hormone. That comes from the parathyroid gland. It's right in the name. So be sure you do that. Okay, parathyroid hormone raises your plasma calcium. It does a multiple thing. It causes you to absorb calcium in your intestine better. It causes you to pee out less at the kidney. It causes you to retain it at the kidney. And it causes you to resorb, or take the calcium out of the bone. Absorption puts it in the bone. Resorption takes it back out. So taking resorption of calcium out of the bone will raise your plasma calcium. So calcitonin puts it into the bones. Parathyroid takes it out. Here they are, these 3 little pea-sized parathyroid glands on the back of your thyroid. This is looking from the back here. And you've got, your calcitonin secreting cells are around in the, in the general area, but they right around here, and the parathyroid hormone, though, comes directly from the parathyroid glands. The parathyroid glands actually have nothing to do with the thyroid gland. That's just a good place for them to hang out. They have, generally, if you have your thyroid removed because of thyroid cancer, you lose your parathyroid glands too. And that's a bummer. They've actually successfully, in a couple of cases at least, taken the parathyroid glands and stuck them on the esophagus, and they live there and keep on working. So it's not like they necessarily have to be on the thyroid gland, but that's where they normally hang out, and that's where they get their blood supply from. So you've got to reestablish blood supply for them. But it's nice to not also lose your parathyroid hormones and have to take supplements for that as well. Parathyroid stimulates osteoclasts to digest bone to release calcium into the blood, enhances reabsorption in the kidneys so that you don't pee it out, and promotes the activation of vitamin D so you absorb more in the intestine. Everything designed to increase calcium in your blood. Your negative feedback is calcium in the blood. When there's too much, you turn off your parathyroid glands. Here's the 3 things, the bones, the kidneys, and also vitamin D so you absorb better. And the negative feedback is the improvement in calcium. Hyperparathyroidism, then, like if you had a tumor that was making a whole bunch of extra parathyroid hormone, what would happen? You'd have too much calcium in your blood. You would have hypercalcemia. And you would also have soft bones because you keep taking your calcium out of your bones. So too little calcium in the bones because it's all in your blood now. Hypoparathyroidism, especially if you had to remove the parathyroids because you removed the thyroid glands, well, you'd have hypocalcemia. You would have to take supplements of some kinds. Okay? Now, one thing important to remember is what hyper and hypocalcemia do to you. It sounds backwards from what you would think it should be. Calcium in the blood has effects on the sodium channels on skeletal muscle. Calcium actually changes the electrical situation around them and inhibits the likelihood of them firing. So if you have too much calcium around, your skeletal muscle doesn't fire as it normally would, and you have what's called hyporeflexia. You have difficulty getting the muscles to fire properly. Low blood calcium causes the opposite effect. Now the sodium channels can fire too easy, and you get muscle cramps. You get tremors or muscle cramps. And the way to remember this is, if you don't want to get muscle cramps at night, drink a glass of milk before you go to bed to raise your calcium. More calcium helps you reduce the chance of muscle cramps. Okay, that's it for that. Now, the pancreas controls blood sugar, glucose, plasma glucose. You produce insulin and glucagon. This is like calcitonin and parathyroid hormone. One of them makes your blood sugar go up, one makes it go down. Okay? Insulin makes your blood sugar go down. It's easy to remember because if somebody has diabetes and their blood sugar is too high, they take insulin, right? Insulin makes your blood sugar go down. Glucagon makes it go up again. Now, your pancreas is a multitasker. It has exocrine glands that are in little balls that secrete digestive enzymes into it, and it has a tube that puts it into the intestine and digests your food. And we'll see that in the digestive part of the course. So you have exocrine digestive cells. And then you have these little blobs of cells called islets of Langerhans. And these are endocrine cells. They're cuboidal cells that secrete insulin and glucagon. The alpha cells secrete glucagon. The beta cells produce insulin. Alpha cells are big and dark. Beta cells are little and pale. Alpha glucagon. Glucagon has an A in it. Alpha has an A in it. Okay, alpha starts with an A. Glucagon, alpha. It's easy to get it backwards. Your beta cells produce insulin, and these are the ones that will take the sugar down by putting it into your skeletal muscle, where it gets stored until you need it for energy. So look at these. Which of these are alpha cells and which are beta cells? Well, look at these big dark guys. Those are alpha cells. Look at these little pale guys. These are beta cells. Okay? This is an islet of Langerhans, and there's an alpha cell, and there's a beta cell. It's pretty easy to pick them out. That looks like a beta cell to me. That looks like an alpha cell. And I'll probably have these on the lab practical, and you'll look and you'll see, well, that's alpha glucagon, and there is beta insulin. Glucagon. Let's look at that first. It's catabolic. It breaks down glycogen and releases this glucose into the blood to raise your plasma glucose. So if you haven't eaten in a long time and your blood sugar is starting to drop, it will break down some glycogen in your liver primarily, which is a good storage place for sugar, and release it into your blood to keep your blood sugar from getting too low. So it also stimulates gluconeogenesis so that you'll make more glucose out of proteins and things to raise your plasma glucose when it's too low. Once again, up until the last 100 years, nobody died of high blood sugar. Nobody died of diabetes. For one thing, they didn't live long enough to get diabetes unless they were born without a functioning pancreas. And then that was a whole different issue. But the kind of diabetes we have from getting overweight and having too much food and having too many nutrients, that wasn't true in human existence until lately with the advent of Big Mac and lots of cheap food to eat. So glucagon was really important. It could break down tissues and raise our blood sugar, mainly releasing sugar from the liver. Insulin, on the other hand, nowadays we eat too much and we're too fat and we tend to get diabetes. And it mostly affects skeletal muscle because that's where glucose goes. It will go into the liver if you need to store some, but mostly you put sugar into your muscle cells. They form glycogen in there, and you use that for energy when you start exercising. So insulin is going to put glucose, plasma glucose, in your muscle cells. If your glucose is too high, you produce more insulin, and the glucose goes down because the sugar goes into your muscles. The kidney, the brain, the liver, those are good storers of glucose that have their own storage mechanisms. The brain especially can only eat sugar. It can't eat fat. Okay, so your brain needs glucose. So do your red blood cells. They don't have mitochondria, so they can't use proteins or fats. They have to live on glucose. So we need to keep our glucose, between 60 and 100 milligrams per deciliter, something like that, to keep us in a kind of a healthy range. Insulin is anabolic. That means it builds molecules. Remember, insulin, growth hormone, insulin-like growth factors. They use those catalytic type of receptors. Those are anabolic receptors. They put stuff into the cells to make bigger molecules. So anabolic steroids, yet they stimulate these growth hormone type cells, type receptors, so that you put more stuff in your cells. And the same thing with insulin. So it has a receptor, a catalytic or enzyme-based receptor, and when it stimulates that, it turns on GLUT4 receptors. It actually disassociates them from an inhibitory molecule. The GLUT4 receptors stick onto the cell membrane and start sucking in glucose. So insulin causes your glucose receptors to move to the surface of the cell and start pulling in glucose. Once there's enough glucose in your blood and you stop making the insulin, then the insulin receptor turns off. This inhibitory molecule grabs and pulls the GLUT4 receptor back off the surface, and you stop taking it in. That's your negative feedback. So just like parathyroid hormone's negative feedback is calcium levels improving, your insulin negative feedback is your blood sugar improving. So here we have, the blood sugar goes up. The pancreas makes insulin. It stimulates some in the liver, some uptake in the liver, but primarily, see this in red, mostly it stimulates GLUT4 receptors on the muscle cells, skeletal muscle mostly, putting the glucose inside those skeletal muscle cells, forming glycogen until you need it for energy. That takes the blood glucose back to normal range, so you can negatively feed back and turn it back off again. If the blood glucose goes down, the pancreas releases glucagon. This causes the liver to release blood glucose, and it brings it back to normal. So that's the pattern. So, blood glucose levels go up. If everything's working, you should release insulin. Okay? Now, in the lab this week, you will see that I'm going to do two things in the lab. One is I'm going to take virtual rats and do a whole thing of metabolic function and thyroid hormone and thyroid stimulating hormone and the like. And so that's one part of it. But the other is I actually did a glucose tolerance test on myself where you fast, and if you're fasting blood glucose, you take that, it should be between 60 and 100 milligrams per deciliter. And then you eat a whole bunch of glucose and you see how your system responds. Your blood sugar goes up, you make a bunch of insulin, your blood sugar is pushed back down to normal levels again. That's the whole point. If I eat a meal that has a lot of carbs in it, most of that becomes glucose when it enters the bloodstream. You release insulin and it puts that glucose in the muscle where it needs to go so that it doesn't keep your blood glucose high. If you're over 125, fasting glucose, that's an indication of diabetes. Diabetes mellitus, which is the sugar kind of diabetes. So here we have diabetes mellitus or mellitus, DM. And if you have type 1, used to be called juvenile, but now, it doesn't matter when you get it. If your pancreas can't make insulin, you have type 1 diabetes, and your only treatment for that is to take insulin shots all the time. It's a bummer, but people have meters where they keep track of their glucose and they give themselves little tiny pinprick shots fairly frequently to keep it under control. That's type 1. Type 2 diabetes mellitus is the kind that you usually get later. It used to be called adult onset, but now kids are getting it too because we have more child obesity and stuff. Obesity interferes with your insulin receptor's ability to function right. You're making insulin, but you're not responding to it right. And there are a couple of things that you could do. You can take more insulin. You can control your diet. You can exercise. Exercise causes your skeletal muscle to take up glucose better, with or without insulin. So if you lose some weight and exercise, a lot of times you can control type 2 diabetes without extra drugs. Not always, but sometimes you can. So, blood glucose levels remain high, even when your body's trying to lower them. Glycosuria, that means that glucose shows up in your pee. And we'll see in the kidneys that when you filter your blood, because glucose nutrients are so important evolutionarily, you don't waste any of them. So any glucose that gets filtered into the urine gets reabsorbed before you pee it out, if you're healthy. But if you have diabetes, there's so much sugar, you can't reabsorb all of it and it starts showing up in your pee. Glycosuria means, you're peeing out some glucose, and you shouldn't be peeing out glucose. Ketonuria. If your cells can't use the glucose like they're supposed to, your body makes ketones. And this is, you go into ketosis if you want to lose fat. Well, yes, it uses fat to make ketones, but it's not healthy. Ketones are a backup emergency plan. Your brain can live on them, but not as well as it can on glucose. What you want is to have the right amount of carb in your blood. You don't want to starve your blood cells in your brain and force them to eat ketones. But ketones, keto acids, produce acidosis. And so ketonuria, you'll find ketones in your urine. Ketoacidosis, your body will become acidotic. You'll breathe faster. Your breath will smell like nail polish remover. It's a lot like acetone. Ketoacidosis can be fatal. It's usually not. People normally control it who have diabetes, but some people don't do a very good job of treating their diabetes. The term diabetes means too much water. It was named because people peed all the time. They pee all the time because you can't reabsorb all the sugar. Sugar stays in your pee, and by osmosis, it draws more water and makes you pee and pee and pee. So you have glycosuria, and that causes you to pee more because of the osmotic forces in the urine. So you pee too much, you're thirsty all the time, you are dehydrated all the time. Type 1, you can't make the insulin in the first place. Type 2, you don't respond to the insulin as well. Usually insulin shots for type 1 will work. Adult onset or type 2, obesity and lack of physical activity, which you can often treat by losing weight and exercising more. High blood sugar. If you eat a meal that's high in carbohydrate, your sugar goes up and it stays up a long time because your insulin can't do its job. Remember, the insulin is going to try to drive that glucose into the muscle, but if it can't, the glucose stays in your blood. High blood sugar, it causes glycosylation of your hemoglobin. It damages your red blood cells. It damages your vasculature. You develop poor circulation in your feet, your lower legs. Sometimes you have to have your feet cut off because you don't have enough blood flow down there. It causes damage to nerves. It can damage the nerves in your eyes and cause blindness or loss of vision. It can damage the nerves in your feet so they become numb. Then you can't tell if you cut yourself, so you get an infection, and you don't have blood supply down there to heal it, so you get an infection that you can't heal, and you get your foot cut off. So that's the extremes. If you don't treat diabetes once it comes on, this is the likely outcome. Here we have someone who had Achilles tendon surgery. They're a diabetic. They ruptured their Achilles tendon, had surgery, and 6 months later it wouldn't heal. Now this is interesting. This is a slide from when I was teaching the hyperbaric program at the medical school. For a couple of weeks, a few weeks, they put them in a hyperbaric chamber, which supersaturated their blood with oxygen. It doesn't drive it in from the outside. They were just able to get enough oxygen through the poor blood vessels to oxygenate the area enough that the immune system could heal the wound, and it healed up. So that's one legitimate use for hyperbaric oxygen is for diabetic wounds that won't heal. Signs of diabetes mellitus: too much pee. Too much thirst, polydipsia. I think of dipping a ladle of water out of a well. Polydipsia is too thirsty. Polyphagia means you're too hungry all the time because your tissues aren't getting the glucose that they need, so they keep telling you to eat more. That makes it even harder to lose weight because you're hungry all the time. So polyuria, polydipsia, polyphagia. Now, the term mellitus actually means honey. Too much water with honey. Honey in your pee. Before they had any tests, if a mother suspected that her baby had diabetes, she would taste his urine, and if it was sweet, she would know there was sugar in the urine. So diabetes mellitus is sugar related. There's another kind of diabetes called diabetes insipidus, which happens if you can't make antidiuretic hormone. There's a lack of antidiuretic hormone means that you pee too much, right? Antidiuresis helps you retain water. No antidiuretic hormone, you pee too much. But that's different. That's an ADH problem. This is an insulin glucose related problem. Hyperinsulin If you had a tumor and you were making too much insulin, your blood sugar would be low all the time. Hypoglycemia. If you've ever felt what it's like to have really low blood sugar, it makes you feel pretty bad. That used to happen to me when I was a kid. I would get low blood sugar. And people take little carbo tablets, glucose tablets that you can pop in your mouth and eat them to bring your glucose back up. Diabetics sometimes too. If you take an insulin shot that's too big, you can wind up with hypoglycemia and have to eat a little bit of carb. So here's some signs and symptoms of insulin deficit diabetes mellitus. And finally, one more gland we'll look at here, because there's no other good place to put it. The pineal gland is a little gland behind the pituitary, up a little bit higher. Roof of the third ventricle is where it hangs from. It has a few different functions, but its main claim to fame is the pineal gland makes melatonin, which helps you sleep. It is cyclic. When you need to sleep, you make more melatonin. When you need to wake up, you make less melatonin. You can take melatonin as a sleep aid. I tried it, but it gave me a headache, so I had to stop. But, that's the main thing you need to know about the pineal gland. The pineal gland, a small, kind of specific gland, and it makes melatonin, which helps with your sleep cycle. And that's it for the endocrine system.